What I want to do is just talk to you a little bit about a public health palliative care approach in our communities. And public health palliative care is an approach that promotes death and a grief as a natural part of life. It acknowledges death and dying as part of that normal lifespan and trajectory, and something to be valued in terms of its care and the support and services that we put into that so that people can live their best quality of life. It supports the process of enabling people to increase their control over their own health and well-being. And that's an incredibly powerful statement for people to be empowered to make choices for themselves about what they want at end of life, at any point in life, but specifically today about their end of life. To best do that, we need information. Public health palliative care approach supports it builds individual and collective resilience in the face of grief and loss. And simply by having this conversation today and opening doors for people to come forward and be part of this conversation, we're increasing the opportunities for that collective resilience. It supports health promotion through not only clinical care, but also action across allied health and also other professionals and family and community. So when it was mentioned before about a holistic frame for care, this is how it encapsulates all of that: professionals, family and community. One of the things we do need to bear in mind is that it's actually up to us to be able to ask for those things and to express our needs. The project, the community conversation, sits underneath the work of Trobe University, and as we mentioned, it's in partnership with Palliative Care New South Wales. Some of the research that's been done by Trobe University in the community, particularly in a range of settings, found a common set of what's called social norms or beliefs or ways of being that impacted our ability for us to not know more, what stops us from actually communicating around palliative care, around things. Some of the things that research has identified, there were four main things. There was a reluctance of carers to accept help when it was offered by family, friends and neighbours. And I think I could probably put myself in that bucket up until a few years ago, because I wasn't particularly good at accepting help from other people. Even when it was offered, I just thought, no, I'm going to be able to do this on my own. Another thing they found in the research was that carers very rarely ask for help. So not only was it a challenge to accept the help when it was offered, people found it very difficult to ask for what they wanted. They also identified that community willingness to offer help was there, but people didn't actually know how to do that. They didn't know how to approach someone, what to offer, so that situation could be improved for someone with a life-limiting illness. And community also didn't provide help. So their offers were refused, and people didn't know how to actually address that again. So they didn't know whether to go back and ask again or to offer. They weren't sure what to do in that situation. Those four things collectively actually limit the amount of support that can be put into a situation and accepted by someone, particularly in an end-of-life situation. So what I want to do is just have a little bit more of a look at that. And there's a couple of best way to do it is to talk about people's situations. So I'm going to read this to you. If you'd like to close your eyes and just listen, more than welcome to do that. So this is a situation that talks about a carer, and she shared this information with the research unit. And it's about Beth. So when Beth's husband died at home, which is an interesting point, she regrettably expressed relief that the care period was relatively short, saying, "I couldn't have coped any longer." When questioned why she didn't reach out to her friends in the choir of 30 years and ask for help during that care period, this was her response. "Well, it never occurred to me to ask them. And anyway, dying is a private matter, and you don't want to ask people to do that, don't you think? and she was screwing her face up as she commented. And the researchers' comment around this was, what would you do if one of the choir members asked you for support to care for her dying husband? So she put this question to Beth. And Beth said, I'd do it in a heartbeat, really. I'd do anything to help them because we're like family. So in Beth's situation, she was more than willing to be able to help someone else, but was unable to actually allow that support to come into her situation because she felt that she would perhaps be a burden. It was a private matter. And maybe there's something in that you can relate to. I know I can. This situation also, by contrast, it's also another carer. And her name was Jane. And this is what was said. So when someone offered to help out, I felt so bad saying no, sending them away, thinking that really they had nothing to offer. So I developed a list of all of the things that would be useful for me, you know, everything like garbage bins, the gardening, doing the shopping, and that made other people, it made them feel involved. And that was important to them to help us. And I couldn't send them away thinking that they'd done nothing and had nothing to offer. They loved my husband, Murray, and they wanted to do something for him. So one of the interesting scenario there that she created a way of people being able to help her in a way that was comfortable for her and Murray, and it actually improved their situation. It wasn't perhaps too personal, but there were things that she really needed done that helped her in caring, being able to release her to have time to care for her husband. One of the things that came out in the research was that people quite often will only ask you 3 times if you need a hand. And if the response is continually, oh, no, we're okay, no, it's all right, quite often those people will actually stop asking. So around 3 times was the feedback that the research gathered in terms of people's willingness to keep offering that assistance. This, by contrast, very different situation. This is around someone just playing a little bit with some of those social behaviours around caring in her community. So this was a lady, and she spoke the following. My friend is struggling to care for her husband. So she's talking about someone else in the community. This lady's exhausted and she's teary, but she won't accept help from anyone. She's very proud. And what I'm finding is that this just isn't a one-off conversation that I need to have with her. I have to keep talking about it, keep encouraging her to ask for and accepting help every single time we catch up. It's starting to sink in. She's starting to see that there's another way that she can go about this. And for the first time last week, the first time, she let me vacuum her house. A couple of interesting things in that is that it's not that one-off conversation. When we're offering help to someone, we need to help them to understand that the help is genuine, that the help is, it's given freely. There's no need for them to repay that help. And it was interesting that she actually let her vacuum her house. I know some people, I know I used to do it. If anyone offered me help like that, I'd run around and tidy my house up before they came. But the fact that she actually let her in to vacuum her house was the first step for that friend being able to accept that help that Janine was offering. And it's not something that happens overnight. We're changing social norms and social behaviours. So the opportunity is to have those conversations with carers, for people who are caring for someone with a life-limiting illness, to be able to talk with them over and over and just gently keep offering and gently keep trying. Don't stop that offering of assistance. This is just a visual, just to give you a little bit more information about the purpose of these conversations and the work that's being done at the moment. In terms of healthy end-of-life partnerships, what we're looking to do is to raise awareness and to link people up, link assets in the community, link networks, unlock little networks, perhaps that people don't know about. So on one side of the graph there on the picture, we've got the health networks that exist in communities, and on the other side we have community networks. And for this healthy end of life, the partnerships to really develop and to be effective for carers who are caring for people and for someone with a life-limiting illness, we're trying to build capacity, to build capability for those carers to connect with community and health, so that that whole care network that's being provided not only by palliative care but also by community, might be friends from book club, it might be someone from Rotary, it might be the girls that we meet with for cards, it could be anyone and anyone. So to bring those networks together so that we build community resilience and we build options for support for carers and for families who are caring for people with a life-limiting illness. And along the bottom, down the bottom there, those networks of care and support can be formal and they can most likely be informal as well. So informal at the community end, that more relaxed contact that we have with people, our friends, our extended families, our social groups, working together with the health networks so that people have a broader range of options. It builds community resilience and it gives us the opportunity to be able to ask for that help and accept it. It also gives community the opportunity to offer that help and provide it